Okay, moving down to the muscles acting over the ankle and the foot. When we look at the lower leg, it is divided up into three compartments, very much like the thigh is. This is done by the deep fascia. Here on this section of the leg, this cross section of the leg, we can see this green line coming all the way around the muscles. That is the deep fascia, and periodically the deep fascia sends intermuscular septa to divide the muscles into their functional compartments. And there are really three compartments, although one of the compartments is divided up into two. We've got an anterior compartment here which contains the dorsiflexors. We've got the lateral compartment which contains the everters, the perineal muscles, and here we've got the posterior compartment which contains the plantar flexors. Now the posterior compartment is further subdivided by its own fascial plane into the deep and superficial plantar flexors. The movement of inversion is produced by the combined action of some of the dorsiflexors with some of the plantar flexors, so there is no separate inverter compartment. Now the anterior compartment is a very tight compartment, very tight fascial plane sitting around that anterior compartment, and it's the commonest area where we will come across compartment syndrome, a clinically problematic condition in which the pressure within that compartment builds up so much that the blood vessels collapse and we get ischemia in this area. Now when we look at the fascia, there are thickenings in the fascia of the lower leg. These are called the retinacula. The majority of the fibres of the fascia are orientated longitudinally. They run parallel to the line of the leg, but across the foot and ankle there are thickenings in this fascia that go horizontally across. These are the retinacula, and their function is to prevent the dorsiflexor tendons, plantar flexor tendons and perineal tendons from bowstringing and moving out of position. Occasionally the retinacula can tear or rupture, which may lead to bowstringing or flicking of the tendons. This most commonly occurs with the perineal muscles. Here we have a diagram of the extensor retinacula. So over here we can see the superior extensor retinaculum, and down here we've got the inferior extensor retinaculum. So this is the medial aspect of the foot over here, and this is the lateral aspect of the foot. The superior extensor retinaculum, it's a series of horizontal fibers that basically pass from the medial border of the tibia across to bind the dorsiflexors down before attaching onto the fibula. The inferior extensor retinaculum is much more extensive. It attaches laterally to the calcaneum on the anterior portion of the sinus tarsi. It then forms this Y-shaped structure that passes, one arm passes across the medial malleolus, the other arm goes over the dorsum of the foot before blending into the fascia of the plantar aspect of the foot. And again, the function of these two retinacula are to prevent bowstringing of the dorsiflexor tendons. So when we dorsiflex our tendons, our skin doesn't stick out like a sail. The flexor retinaculum is situated on the posterior medial aspect of the ankle. So here we've got the medial malleolus. Here we can see the calcaneum. This foot is obviously in plantar flexion. And there's the flexor retinaculum. It's a very tough, very strong fibrous band that is bound down over here to the posterior aspects of the medial malleolus, and it extends down to the medial aspects of the calcaneum. Now, again, what we have here is the flexor retinaculum is divided up. On the deep surface of the flexor retinacula, there are intermuscular septa. There are sheets of fibrous tissue that go off and attach to the bone that divide the retinaculum up into four separate tunnels. In these tunnels we have the tendons of tibialis posterior, flexor digitorum longus. We've then got a separate tunnel for the nerve, for the tibial nerve and the posterior tibial artery and tibial vein. And then the final tunnel over here is the tendon of flexor hallucis longus. And most medical students remember the order of these tendons by the term Tom, Dick and Harry. So Tom being tibialis, Dick being digitorum, and being the artery, nerve and vein, and Harry finally being the tendon of flexor hallucis longus. The perineal retinacula are found on the lateral aspect. There are two parts to the perineal retinacula. Again, we have the superior perineal retinaculum that we can see here. This forms a single tunnel that goes from the lateral malleolus across to the calcaneum. The two tendons of peroneus longus and brevis pass through this tunnel in a common synovial sheath. And then we've got Down here on the lateral surface of the calcaneum overlying the perineal tubercle, we have the inferior extensor retinaculum. This time this is divided up into two separate tunnels, again by an intermuscular septum, separating out the tendons of peroneus longus and peroneus brevis. Now, the inferior perineal retinaculum appears continuous with the inferior extensor retinaculum. This is the one that's most commonly injured. We can often see tears of either the superior or the inferior perineal retinaculum, and as a result of which the patient will often come in complaining of flicking of one of these tendons, one or both of these tendons, which may not necessarily be painful, but may be just a little bit disturbing to them. As the tendons themselves pass under the retinaculum, so here we can see a foot, there's my inferior extensor retinaculum here we've got the superior extensor retinacular, the two perineal retinacula, there's the superior one and there's the inferior one. Now as these tendons pass underneath this retinacula, they do so encased in a double layer of synovial membrane. Now this double layer of synovial membrane is sealed at the end, so up here this will be sealed. There is a thin film of synovial fluid separating these two layers of synovial membrane, and they act like sleeves. They're like a double sleeve that goes over each tendon, and the function of these is to prevent friction of the tendons as they pass over the bone or under the retinaculae. You can get irritation of the synovial sheaths. This is a condition known as tenosynovitis, or it occasionally is termed tenovaginitis as well. It's a relatively common problem. The synovial sheaths themselves are highly vascular, and they are anything that's highly vascular is often very painful indeed, and it's because it's well innervated. So these synovial tendon sheaths can give you a significant amount of pain. It's usually an overuse syndrome that we see, and because of the good vascularity of the synovial tendon sheaths, they do generally respond quite well to treatment. Okay, so moving on to the muscles themselves, we'll start off looking at the plantar flexors. Here we've got the posterior aspect of the calf, and we can see that the first muscle that we come to, so as we skin a limb, the first muscle that we come to is this huge structure across the back of the calf. This is the muscle called gastrocnemius, and gastrocnemius arises from two heads. It's almost like two muscles blending into one. An incredibly powerful muscle that crosses the knee joint as well as the ankle joint. It is our explosive plantar flexor. In terms of fiber type, this is made up predominantly of type 2 muscle fibers, so its function is predominantly for fast activities. Proximally, here it attaches to a facet above the medial condyle of the femur, and on the lateral aspect of the condyle, of the lateral condyle of the femur, just above the attachment of popliteus. The two heads pass distally, and they converge together to form this thick, strong tendon, the tendon of Achilles, or the Achilles tendon. Very, very strong tendon indeed, that as it runs down the back of the leg, it twists very slightly, it spirals on itself before attaching onto a ridge across the posterior aspect of the calcaneum, a horizontal ridge across the posterior aspect of the calcaneum. Now, as gastrocnemius passes down the tendon and forms its portion of the tendon Achilles, it blends with a deeper muscle, with soleus, that also contributes to a portion of the tendo Achilles. A very strong muscle indeed. I say its primary action is to produce powerful plantar flexion, but because it crosses the knee at the back, it assists with flexion of the knee. Okay, deep to gastrocnemius. If we peel gastrocnemius back, we see this muscle here, soleus. Now, soleus is again a fairly large muscle. It's a single joint muscle that blends into the tendo Achilles in the same way as gastrocnemius does. It has a fairly extensive linear attachment. It arises from the medial border of the tibia, from the middle half of the medial border of the tibia. Now, across the back of the tibia there is a line, there's an oblique line called the soleal line, to which the top of soleus attaches. It then has a small fibrous arch where there is no attachment. This is for the passage of nerves and blood vessels, before attaching onto the posterior aspect of the head and the upper third of the shaft, or upper half of the shaft of the fibula itself. So it's got this big inverted U-shaped attachment, and it acts like a hood over the deep plantar flexors. The muscle itself runs down, forms the deep portion of the Achilles tendon before inserting into the posterior aspect of the calcaneum. Now, together, gastrocnemius and soleus are often called triceps surae. They work together. They're two muscles that work together. The gastrocnemius component will also flex the knee as well as plantar flex the foot, whereas soleus only plantar flexes the foot. They're both supplied via the tibial portion of the sciatic nerve, the nerve roots being from S1 and S2. Typically, soleus is made up predominantly of type 1 muscle fibers, so it's very much a postural muscle. It's the muscle that works when we stand to stop us tilting forward. And you often find that people who are in occupations that involve an awful lot of standing, so nursing, hairdressers, people who are on their feet for long periods of time, will often have very well developed soleus muscles. And soleus is a slightly lower muscle than gastrocnemius, so consequently it changes the shape slightly of the calf. When you've got somebody who's got a very explosive calf, lots of gastrocnemius, the bulk is at the top, whereas soleus tends to be slightly broader lower down. Now, when we take away gastrocnemius and soleus, deep to these muscles, we find three more muscles: tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And these three muscles all arise from the posterior aspect of the tibia, fibula, and the intervening interosseous membrane. The first muscle, tibialis posterior, is a very strong plantar flexor and inverter of the foot. It arises from the posterior aspect of the tibia, hence the name, tibialis posterior, but below the level of the cilial line. So where soleus comes across onto the cilial line here, tibialis posterior arises from below that. It also has a significant attachment onto the posterior aspect of the interosseous membrane and a small attachment onto the posterior aspect of the upper part of the fibula. The muscle itself runs obliquely down, passing behind the medial malleolus, running underneath the flexor retinaculum, in the first tunnel underneath the flexor retinaculum, and as it runs down, it's encased in its own synovial tendon sheath, before darting off here to the plantar aspect of the foot. It attaches predominantly to the navicular tuberosity, but then also sends slips to the medial cuneiform, the three middle metatarsals. It's a very powerful plantar flexor. Its actions are to plantar flex the foot, but because it lies medial to the foot as well, it will also have a significant role in inverting the foot. It works with tibialis anterior to invert the foot. Again, this has its nerve supply from the tibial nerve, nerve roots L4 and 5, occasionally a small branch from S1. I apologise for this diagram, it hasn't come out, my scanner seems to have been playing up, but this is supposed to represent flexor digitorum longus. Now, flexor digitorum longus, again, has a fleshy attachment arising from the posterior aspect of the middle half of the shaft of the tibia, again below the level of the cilial line, running almost underneath tibialis posterior. So it also has a small attachment from the adjacent interosseous membrane, so some of the fibers will come from the adjacent interosseous membrane, and the tendon of flexor digitorum longus passes again under behind the medial malleolus, then it goes under the flexor retinaculum and lies on the medial aspect of the sustentaculum tali. From there, it then darts across the sole of the foot and it splits into four tendons. I don't know if you can just make out these four tendons going to the four lateral toes. As the tendon then splits, it passes to the distal phalanges. As the tendons go to the four lateral toes, they go through a split in the tendons of flexor digitorum brevis. Flexor hallucis longus is a small, incredibly powerful muscle that arises from the posterior aspect of the lower two-thirds of the fibula and adjacent interosseous membrane. It has a short, tight tendon that passes between the two tubercles of the talus, passes underneath the the sustentaculum tali before passing to the distal phalanx of the big toe. It's a very strong muscle, incredibly powerful muscle that can sometimes get impinged at the back of the ankle here. Its action is to plantar flex the big toe, and it's very important for the final propulsive phase of the gait cycle.